medical director of the hospital, and I left the place to Fabio Taccone, the well-known Fabio Taccone, and I have the big pleasure to chair this session with Vittoria Metaxa from London. London. And she is the expert in palliative care. I will be the bad guy. She is the expert.
Hi, everybody. Yes, don't forget, I am the expert. Just remember this for the next half hour and everything will be absolutely fine. This is meant to be informal, and this is meant to be a conversation between us, and it's nice to see people here for this kind of talk. In conferences like this, palliative care was never a topic because, you know, why would you need to talk about palliative care when you have sepsis and cardiovascular and antibiotics and ventilators? Why would you need to do that? But it's so nice that you guys showed interest and you're here. And the way we thought we're going to do this is I'm going to give you maybe a definition of what I think palliative care is in intensive care. And then, I don't know, I'll ask you questions, you ask us questions, and we'll see what happens, all right? Because this is meant to be informal and not a tutorial. So I'll start by giving you a bit of the WHO definition of what palliative care is. And please remember, this topic is palliative care in intensive care. But let's just do one thing at a time. So come here. Come here in the front. The humiliation of the late arrival. There you go. All right, so palliative care is this umbrella of a specialty. It is not a specialty because in some countries I don't think there is a specialty of palliative care, and I think I would be very interested to know what happens in your respective countries. But it is an umbrella, it's an approach of how we deal with people's symptoms when they have a time-limiting disease. So symptoms, support for the patient, support for their family, spiritual support, emotional support, systemic support. So this umbrella of many things. It encompasses how we communicate with the patient, how we communicate with their family, as I said, how we control their symptoms, how we support them emotionally, how we support the staff emotionally. And it's not just around end-of-life care. It's when someone has a life-limiting disease, and you could argue that being in critical care has a time-limiting disease. So that is the definition. Jacques, I don't know if you want to say something, because otherwise I'm going to start asking.
No, the idea is that because I will be the bad guy, I really do not understand why, you know, as an intensivist, you must, you know, define what for me is best practice medicine, is communication with the family, communication with the patient, treat pain, try to avoid anxiety for the family, and blah, blah, blah. So why do you need to, let's say, okay, I have the curative acute treatment, and I put on this palliative care only in patient with, let's say, a decision of end of life, something like that, because for me, everything must start when the patient is admitted. So that's it. We don't want to speak together. You have to raise your hand and say, no, I don't follow you, that's not correct. Yes? You have to...
I'll give you, no, it's all right.
Just a question. What is your mortality rate in your ICU? The average mortality rate in your ICU?
15%.
And so why are you so good at putting catheters, ventilating patients, and why are you so bad at leaving a vast majority of patients that we know we are going to die? And why aren't you training these kind of skills? I think that's my answer to your question.
So it's because you consider that the intensivist, which is an anesthesiologist or internal medicine, if he choose this kind of medicine specialty, it's because he need action. It's something probably is more in action and less in empathy or less in communication. I don't understand that. Why do you need? I think that by the definition given by Victoria, a good intensivist can do palliative care normally.
Anyone else? Yeah.
I'm the bad guy, huh?
Yeah.
I play the bad guy.
So I'm just thinking, Jacques, I'm just thinking that, yeah, you're absolutely right. But perhaps what I've experienced over maybe the last 15 years is a change in requests for intensive care admission. So not infrequently now, we will be asked to see people who are very far on the end of a disease process, a major cancer, who've been through multiple trials of drugs and this and that and the other, and they're going to come in and maybe they're going to have some high flow oxygen, some vasoactive agents, some renal replacement therapy, another special new drug given, but we are being asked, and we're being asked right from the start, if it doesn't work, that's fine. If it does, that's fine. And then we're going to palliate them, but we're going to palliate them in the ICU. It's going to be our job to palliate them. And that wasn't something that we did routinely in that sort of way 15, 20 years ago. So that's what I think this is about. I think it's about a change in focus for the ICU, and is it reasonable?
So listen what happens here. A very good comment, I think. Definitely the pressure, the demands and the expectations for ICU has definitely changed because society has changed. It's not just ICU, but society has changed and the way people view death has changed. But look what happens here. We were talking about palliative care, the all-encompassing definition that Jacques was saying of not just people who are about to die, not just people who come to ICU to die, but all people that are ICU patients, who are ICU patients because their life is at risk. So one first thing that I definitely want to put out there is please don't think that palliative care is only about end-of-life care. Don't think that palliative care only comes into play when someone asks you to, I don't know, admit someone you think they're going to die, or someone's dying, or you withdraw treatment, and that's where palliative care in any form comes in, because that's not it. And I think the answer I would give to Jacques is probably, I don't know you, but what about each of you? Do you ever call the endocrine team in your ICU? Do you ever call the cardiologists? Some people say yes, some people are like, look at me like, hell no. Do you ever call, who else? I don't know, do you ever call any specialty? I mean, why do you call the cardiologist? Surely you've all graduated, well, majority or someone, you've done medical school, right? You've done nursing degrees. Surely you can read an ECG. Can you not? I'm sure you can. But then, please say yes. Thank you. I'll take this as a yes. Yes, you can. We all can, even I can. So, but why do you call the specialists? Because they are specialists, and you call them when the situation exceeds your not abilities, but needs something more than the basic skills. So, one point for me: palliative care is not end-of-life care. It does help. The skills, let's keep it at skills. The palliative care skills will help with these referrals of patients you think they would never come to ICU, or when they come to ICU you think it's inappropriate to continue or whatever, but it's not end-of-life care. And I agree, palliative care skills is not this amazing balloon pump, ECMO type of thing that only the specialists have. Because can I ask you, how many of you here work in countries where palliative care is a specialty by itself? I do. Oh, okay. The majority of you. I mean, I am from London, but I'm Greek, so I've started in Greece, and I can tell you that in Greece there is no palliative care. So if we have this conversation saying palliative care in ICU is imperative and you can't do without, what happens with the majority, and I can tell you is the majority of the countries in Europe that don't have this kind of specialty, what happens to the patients? So I agree, the basic skills we should all do. So can I ask, or do you want to... I can ask them something, can I? So what do you think the basic palliative care skills are? And do you think you have them? So do you think you do palliative care in your ICU? Yes.
I'm from UK to Wexham Park Hospital. We do use a lot of palliative care team, and one input they can give is advanced care planning. And I think this is taking the patient through the journey of, they might get through the ITU, but it's quite likely that, like you said, it's life-limiting. So we use them for the advanced care planning, and this is probably more than my capacity as an intensive care consultant. Yes, we invite them to intensive care if, for example, if the patient, often there is sort of long-term patients, we are sort of trying to discharge them from intensive care, but it's quite likely that they would not be readmitted. So there is a limitation of escalation. And then to plan the advance sort of with the family, with the patient.
May I ask you a question? So you invite palliative care, let's say, doctor in the ICU, that's it?
Yes, we work.
And they are coming from, they mainly work, let's say, in what we call in Belgium, palliative care room, like an hospice. I don't want to say that
No.
Okay, just...
We have a palliative care team in an acute hospital,
okay.
And they will get involved when there is a difficult conversation about the advanced care planning, end-of-life care decisions. They support the patients in all the wards in the hospital. And yes, sometimes we also, for example...
So it's a moving team.
It's a moving team,
yeah.
And it's led by the consultant. And when we have a complex case in intensive care, we often use their help.
Thank you. So that's the answer to a different question, is when do you invite if you have an external palliative care team, how can they help you? But basics, what do you do every day that you think is palliative care? Or do you think it's all intensive care? I mean, I'll come to you in a second. This is really an important topic, and I'll tell you why it's very important. Because somehow, for the last decade, I think, and starting, I think, from North America, with Randy Curtis and everybody else, well, Randy Curtis mainly, this is this huge push to think about palliative care in intensive care. This is very important because I think if we think that the referrals to ICU in Ireland or the UK have changed, I mean, the US is a completely different ballgame, I think. So I do understand, but please remember that we work in very different systems. So before we come and adopt something that works very well in North America, let's see what happens in our hospitals, in our countries. Okay, so what skills...
Sorry, I was actually just about to answer the question that you were saying about when do you get palliative care involved, not specifically about the skills, but I'm also from the UK. At the Royal Marsden, because of our patients being purely oncology patients, we have a lot of surgical HDU after their operation, but we have a lot of emergency admissions. And we've recognised that palliative care is actually quite essential for those admissions. And that's why, to prompt referrals, every emergency admission has a form. And if the form is triggering them to have a needing early palliative intervention, then we refer them. And so the point is that we refer them at the door at their emergency admission. Now, that's become part and parcel of the admissions process onto ITU now. But we have stigma. That's the biggest issue that we have, is stigma, and we've had to change the name in a way of palliative care to symptom control and palliative care, as a way to kind of ease people into understanding that, especially when cancer treatment is seen as treatment and curative until the point that you say, well, maybe there isn't a cure to it, and things like that. And so stigma seems to be the biggest thing, and palliative care are quite trained in being able to address that stigma, I find, more so than the parent teams or the interventionists, personally speaking.
I'm a nurse in the US, and so it's interesting to me because I know, I'm sorry.
After slugging off
because
the
you
US.
said, palliative care is very already present there. But I also, I have a question, because I think that how the US deals with end of life, we let people live for a really long time, and so I'm curious, and I don't totally know, is when you decide that someone's like kind of at futility of their stay, like what is that like? Because I think there is a difference in the US of what we do, and because the family wants it, right? They want to continue leaving someone who's never going to get out of the hospital, and we just continue full court press. And I get the impression that that's not the same, maybe in Europe or wherever, but I'm curious. I think that may be the difference, because palliative care where I work is very involved. I mean, someone comes in stage C, heart failure, automatically palliative care is involved with their care for the rest of their stay. And so I'm like, what do you mean you don't involve palliative care? Like, they have this whole subset. And I think in my experience with physicians of brilliant intensivists, 1 week, someone has a plan on how the treatment goes for a patient, and that's true with end-of-life care and the meds that they order. The next week, someone has a different plan. So what I appreciate about palliative care is that they bring in this commonality so that as a nurse, you provide the same treatment and there's less like moral distressing because, this intensivist is this week versus this intensivist next week. And I like the commonality that it is. And so it's kind of, I'm glad I'm here, but I'm like, wow, really? It's not a common thing to use palliative care, but I guess I'm from the US apparently, so.
Okay, yes, I'll be careful.
No, but we do that, but we don't call it palliative care. Because,
What do you call it then? Who do you call?
it's part, it's patient-centered care, family-centered care. It's open 24 hours a day, the visit for the family. It's try to improve communication with family and blah, blah, blah. All those things, for me, it's what you call palliative care. That's right. Of course. If you are a good doctor, a good intensivist, you have to do that. And I don't think that there is a difference in US and Europe in some country in terms of, let's say, what happens after the decision in end of life, clearly. But I'm not sure that this will influence the concept of palliative care, but because, as you told, palliative care is not only for patient in the end of life.
I'm a nurse. I work in London as well, Guy's St. Thomas. Well, yeah, we have, because we are the, that's fine, whatever. So we have a really good palliative care team, and we have brilliant nurses. I'm a nurse. And it's like, we really struggle with intensivists. Our intensivists as well. We have like half bad, half good, because they tend to reach the palliative care where the pain is too much and when the chronic is already in. So we don't treat the acute when I think we're supposed to start a little bit earlier. So we arrive to have a referral, as she was saying. Yes, they do, but if the nurse doesn't prompt, or if what happened? What the actual consultant does? Nothing, I'm telling you. Because they trying to think that is actual pain, an acute one that can be solved with just increase fentanyl. Doesn't work like that. Fentanyl won't act on that. We need something on top.
Thank you very much. So this is very interesting, okay? So this is this is exactly what I mean. And for me, this is really, really important to understand that fundamentally, I think we are all talking about the same thing. But we need to find a language that it's common so that we can communicate with each other. Because otherwise, people will say, oh, how can you not get a palliative care team? So what did we hear? We hear that palliative care helps with advanced care planning, with difficult decision-making, with pain control, and provides a unified approach.
Yeah, sort of continuum in care.
Continuity of care.
Continuity of care.
Continuity
I like
of care.
what you say.
But ultimately, if you think about it, what does that mean? If you work in a country that doesn't have a palliative care team, or if you call the palliative care team too late, what does that mean? That should not automatically mean that your patient shouldn't get the optimal care throughout their stay. So this is what I'm trying to say. Be very careful, and I think that's, I guess my second point. And I have an issue with triggers. I have an issue with something that triggers palliative care to come in, because it should be something we all do at a basic level, like we all read an ECG, some better, some worse, but we all read an ECG. So you don't need to trigger a palliative care response. You are providing, you do need to have the palliative care skills. And what we need to strive for is we need to strive for continuity. I mean, I've never heard what you said before. I mean, my unit, that never happens. Communication never breaks down. We're one in mind and heart in my unit. Way exactly. But what really needs to happen, doesn't it, is we need to understand that this is a problem. It's a problem for the colleague that was before us and comes after us. It's a problem for the family that we give mixed messages. It's a problem for the nurses that we always forget because, you know, but they are the ones that actually care for the patient. So what we need, we don't need an external team. If we have them, great, but we don't really need the message to pass through in all countries, low, middle, high-income countries. Yes, you don't really need a team. It's part of the training. It's part of the training to understand that advanced care planning, should really start when you're intubated in ICU. Advanced care planning should start from your GP. If you don't have a GP, you know what I mean, as you grow older with the doctor that you have. So we're talking about the same thing. Clearly there's a team. Clearly there's a team that has special skills, but please, part of our job as intensivists is to provide everything that you said the palliative care team does.
So I guess that was going to be my question, because I feel like coming from a more like medic ward background, we're all really encouraged as junior doctors to try and talk to kind of all patients about their kind of treatment escalation planning, regardless of whether we think they're going to die or not. And that's something that's trying to move into intensive care, is that we should have that conversation regardless of whether we think they're going to die on intensive care, because in that conversation you might unravel that they have particular views about their end of life, which, as you said, being on intensive care makes them more likely to be closer to that situation, even though we have high hopes that they will be discharged and be well. So I don't know if that is an answer in terms of what things can we all do that's palliative care. I don't know if I'd call it palliative care, but I think we should talk to all patients about treatment escalation planning before it reaches the point of having to create an advanced directive. What do you think about that? I'm just about to present my poster in about an hour, so I'd really like your opinion.
I think I'll probably be judging your poster, so, you know, hold that thought. No, I agree. I agree. I have a small issue. I mean, I've got many issues, but I've got a small issue about advanced care planning, as I said, when the patient is in intensive care, critically ill. And there's a real push. I mean, in the UK, at least, it's one of my bugbears, that you go down in resus and, you know, it's very busy and there are alarms and everything. And then you hear behind a curtain a poor junior doctor, you know, talking to a patient, and if your heart stops, would you like us to restart it? And the patient's there with sats of 80. And then you choose that moment to get this. And the poor patient, who knows what they say? Do they understand? Do they not understand? But this is what we do. We push our doctors to have this conversation at any point. This is not palliative care, not the way I see this. This is not good medicine. I don't know what happens here, but in the UK, there's a tick box now. Have you discussed treatment escalation planning with? And it's that. It's a tick box. Everybody needs to think about their mortality, or prompted to think about their mortality. But thinking about mortality is also very individualized and very cultural specific. There are some cultures that will not think about their mortality. I don't think that makes them bad patients. You need to work around this, accept this. I don't know.
Fully agree. Fully agree. Nothing else to add to this. Do you think that, let's say, you need more structured palliative care when you have less, let's say, for example, nurse per bed? It's a problem, you know, if you have a lot of, let's say, paradise, you know, a lot of nurse who can take care of the patient, and so I don't know. It's just a question.
I mean, I don't know. I do agree with you.
Because in UK, you know...
we don't have many beds. That's why we have many nurses. I think that's what happens. It's the opposite. It's the opposite. I think you're right. I think a lot of the basic palliative care skills our nurses offer it. I do believe, and whoever's a nurse from the UK, correct me if I'm wrong, we don't give them the training. I don't know what happens in the US, but our nurses...
No training.
Not real, is it? Yeah, so interesting, yeah. Is it the same?
I mean, we get like one class in nursing school like a long time ago, and it's very like, specific to your unit. Like the oncology nurses, I'm sure are better versed in those conversations than, other areas. But yeah, I think just to kind of add onto this, as a nurse, I think palliative care really helps with the moral distress that happens with the different situations at the bedside. And especially in looking at how our patient population has changed in the last 10 to 15 years and will continue to be more sick, even on the ICU providers too, right? I don't know what the acuity is like here, but it's certainly, in my 16 years of nursing, I've never seen this many sick patients. And to see our provider team be so, stretched thin with putting in lines and doing the ICU management, it's really nice to have the palliative care team to be able to have those conversations when we're all stretched really thin. But I just find you guys are so brilliant at what you do that what you provide helps with moral distress at the bedside for nursing and the burnout of nursing. And I can't totally articulate why, but I find them so important for that.
Yeah.
And if I may, you can even extrapolate to the other ward of the hospital, because clearly, people who are now hospitalized are not the same than 20 years ago, and the case mix has changed, and it's very difficult for all the people working there. Yeah. Sorry.
No, that's fine. Like, it's a back-to-back conversation, so it's okay. For example, to avoid these kind of things that nurses or doctor, they miss this kind of training. What we do in our trust is like we have one dedicated nurse, senior nurse, for each kind of specialty in the unit. For example, I'm the one who does the tissue viability stuff. And I provide teaching for the junior doctor and all the nurses once a month for everyone. And the same does who is the link nurse for the palliative, who is the link nurse for that. And we trying to, as I said, like reach most of the people, like, junior doctor, PA, because now we have lots of, at least in UK, physician associates. We do this, so maybe if you have, we are short nurses either, so, but you can find like one that is interesting to have this kind of training that she can have, or he can have this kind of training, and then trying to teach to others, even on the bed space.
Yeah, and who has used simulation just to, learn how to approach family, give bad news? How many of you have done this? Because when we think about simulation, we think about CPR. Huh? But there is wonderful tools with simulation and to, let's say, to be trained to announce bad news and how to speak to the family and so.
So I think again, see how many things palliative care is. It's support for the nurses at the bedside, is providing this guidance, and you don't need to have it's lovely if you have a specialist team, and it's lovely if your specialist team, like at the Marsden, cares, is interested in your ICU, so they create these links. But some places, they provide this moral support by having a psychologist or a social worker, and I still believe that what we need is more education around this. We seem to educate our doctors and nurses for the technical bits quite a lot, but then we leave them hanging a little bit for everything that is palliative care skills, and that's where the problem is. You put them in a conversation with no simulation in comms, with no training, with no human factor training. So everything that goes wrong in a family conversation is because the family is difficult. It has nothing to do with you ever, because, why would it? Exactly. And you don't learn these things. So then you create, situations that are very distressing for you, because you care for patients that you think it's inappropriate, for your nurses, and for the families. So, it's a skill we should all be training at, be educated at, and because we don't, in some countries, mainly North European, Central European, North American, because nobody else has this strong palliative care ethos. Another team came and did it, whereas I think we should all be doing it. Okay.
Thank you. So I agree with everything you said. But the problem, it's not the people that are here. We are probably the ones that have the sensitivity to understand that's something we need. Yes, so my question to you is, how do you reach the other physicians, the other nurses, the other healthcare professionals to raise awareness about this issue? Because that's not something we can do by ourselves. We can have the training. In my setting, some of us do have the training, but it's not something you can do alone. You do have to have a team with the same, language, common grounds. How do you propose that we reach other people? Because I really had trouble to finding box 1 in the Congress. It's in the most far end of this Congress. So, how do you address? How do you think you will address this in the future? To give this more visibility, I don't know.
Jacques, that's a very good question. And yeah, do you have an answer?
Part of the answer? Part of the answer?
Part of the yes. What I was going to say is you should be thankful there is a box 1 for us, because I'm not joking. Because if you go back to this conference and other conferences, there was no mention of it. Yes, there was no publication in high impact factor journals in anything that's related to palliative care end of life. But now there is. You guys, you're the future, right? You're the future bosses, you're the future leaders. You will influence more people. We'll get there. I mean, that's my thing. I see the slight shift. If we can, for this reason, I think we shouldn't alienate this topic. We shouldn't make it palliative care is given by the palliative careists. You know what I mean? The specialists in palliative care. We should make it and just show it that we all do it. And let's just do it better together. That's what I think.
Thank you. Thank you. I agree with you, because I think it should be part of the good clinical practice. Absolutely agree. And I also agree with you that advanced care planning in ITU comes too late. But it's better late than never is one thing. And I think we've been talking about here that, we don't need palliative care teams. So if we are lucky enough to have palliative care teams, then I think this is one of the opportunities we can use to teach these skills to the rest of the team in ITU, to the rest of the hospital. And so I think we shouldn't say that we don't need palliative care teams. I think we should use them as a resource and learn. And we don't need them in every case, but I think it's about using the resource and, the countries who don't have palliative care, and I'm coming from Estonia originally, we now have palliative care and things are getting better, and I've been one of these people who have been going there to talk about it. So I think there's quite a big international, we work maybe not in our birth country. So let's take this message back home. And
how do you measure the efficiency of palliative care?
Gosh, yes.
No, because it could be a part of an answer of your question. I'm clearly not a fan of accreditation and blah blah and Canada accreditation, but our work is evaluated by people coming in the hospital, family, and so with an improvement of family satisfaction can be a good indicator, and I think that we must go in that way, because otherwise we'll never be the let's say to young doctor, you have to train, you have to go to simulation and blah blah blah. We need indicator to be sure that what we are doing is efficient.
And that, I agree 100%. And this is why, apart from these conversations that are very important, because the end of our patients speaks to us all. There is a very scientific base below all this. Please don't think that all this is just fluff and we talk about our feelings and then we see kumbaya by the fire. This is really, really scientific, and this is the reason why. If you want to get trained, you need someone to fund you. Even if you don't have a specialist palliative care team, but you feel like your hospital needs to train you or your university needs to train you, you need to show them how. And we haven't found commonly agreed outcomes for palliative care in ICU. So then you go to your director and say, look, we've been doing badly at family conversations, conflict, I don't know, staff morale or whatever. Give me some palliative care skills and I will make them. So we haven't found, so A, we don't know what interventions are palliative care interventions in intensive care, because we all think different things. And B, we don't know the outcomes. And this is what we're all trying, well, some of us are really trying to figure it out. Because if we have specific measures, then we can bring this forward.
Yeah.
I'll do this.
How to dissociate the terms palliative care and end-of-life care? How?
Very simple answer.
It's a big problem.
No, end-of-life care is a part of palliative care. Palliative care is a big thing, and end-of-life care is part of this. For me, that's it, if I understand well.
I agree. I think people and other people have referred to this. There is one of the barriers for getting a palliative care team in ICU is because in the majority of, not only just the families, like the surgeon's mind, if you talk palliative care, somehow not you just ease them, like you just invite death. I mean, the whole name of palliative care has this magical property that you just, if they come in, death follows them. And it's very difficult, isn't it? It's very, very difficult. I will tell you this, I really believe that we shouldn't change names. Like in my hospital in the UK, the special nurses for organ donation, they never introduced themselves as special nurses for organ donation. They introduced themselves as support nurses, specialist nurses. I think we should call the things as they are. And palliative care is a big part of palliative care, is end-of-life care. It's not synonymous. But I don't think we will shy from the problem by changing a name. We shouldn't. We should educate people. First of all, clinicians, ourselves, and then society. That's what I think. But people disagree, I understand.
So we are 15 minutes after. And if, because you said that box one is very difficult to come, and if they switch off the light, we will be here, tomorrow morning, so